Hi everyone, thanks very much for coming. I'm Kerry Abel, the Chair of Abortion Rights, and we campaign for safe, free, legal and local abortions for the 1 in 3 that need them, that want them and that might have to have them in the future. So welcome to our series of abortion rights summer school sessions. The first one last week on intimate partner violence was really great, and we've got a series of 4, so the next one is called Going Beyond Choice, Abortion Experiences of People of Colour in the UK. That's on the 23rd, and then on the 30th of June, we've got a session called What We Can Learn from Anti-Choice Narratives. So it's all Wednesdays in June, and they all start at 7 p.m. for an hour. So we'll put the link in the chat when the time's right, so you can book your next one. But this session is titled Abortion Poverty, the Hidden Cost of Abortion, and we have a really prestigious selection of speakers this evening. So I'm just going to do some housekeeping just to keep us all organised. We'll be on for an hour, and the speakers will introduce their areas for about 45 minutes, and then we'll have about half the time for your questions. So feel free to add your questions in the Q&A box. That's the easiest way for us to manage it. And please also, a bit of a plea, get them in as soon as you think of them, because we ran out of time a bit last week. So as soon as you've got questions, let us know and we can build that in. Feel free to talk about us on Twitter. It would be lovely if you tagged us. We're at abortion_rights. So tag us there and you can have a look at what other people are saying as well. We're recording this session, so we're aiming to put some clips out on Friday in our newsletter, and then later in the summer we hope to have fuller versions of the sessions, the abortion rights summer school sessions, on our YouTube channel, alongside last year's summer school sessions. And just a kind of abortion rights campaign piece of admin. If you want more articles and updates and events to attend, sign up to our Roundup newsletter, which comes out every Friday at 8 a.m. There'll be a link in the chat to sign up to it if you're not already. So I'm being very prompt because I feel like we've got lots of great speakers and I want to maximise that. Thanks very much to the audience and the speakers. We can't do this without you. But before I really get into it, I just wanted to make sure I thanked Elisa Berry Ryan and Davinia Hamilton, because not only did they physically make these events happen and do all the work to promote them, but they were also influential in shaping the tone and the content of them too. So I wanted to flag that. A whole list of links that you can sign up to. You have to make save all of those in one go. I'll do a quick introduction to the session. The purpose of this panel about abortion poverty is not to be alarmist. You may be aware that there are 200,000 abortions a year, a fifth of all pregnancies globally, and we're not arguing that abortion is entirely inaccessible for most. But we should be clear that just because abortion is legal, it doesn't always mean everyone has equal access to it. I think we've been acutely aware of this during the global pandemic, but even outside of a global pandemic, poverty is a hurdle for women seeking abortions. For the poorest in our society, finding the money to travel to appointments, to get childcare, and if necessary, staying overnight is unreachable. Abortion also comes with aftercare costs, like heavy bleeding, having to get extra large sanitary towels to manage your abortion, and getting pain relief drugs. And sometimes even these things can be a struggle. We know that working class women have always had fewer options and worse access to abortions. Their communities are also worse catered for contraception and for abortion services, but also things like public transport and affordable childcare, which lessen the burden if it's available. Lower paid jobs and vulnerable employment mean that giving up their shifts has felt harder, and we argued these points really hard when we made the case for telemedicine, and that is currently being considered to keep telemedicine after the pandemic. we submitted the consultation, and we're really waiting on the Scottish Government and the Westminster Government to consider that. We often have to emphasize this, but abortion access isn't just about the law. That's not the only part of our campaign. It's about funding and service provision and information about options and easy access to services. So that's enough for me. We've got 4 speakers tonight. It's very international. We've got speakers from Canada, Malta, Scotland, and England. So Veni, Mara, Catherine, and Audrey. I'll introduce them properly before each one. So you don't have to remember everything. First up, we've got Veni Al-Siora. She is the Director of Women on Web and an international telemedicine abortion service with 15 years of experience providing access to medical abortions to those with limited or restricted access, and groundbreaking in their approach. Veni has worked in social and health protection for over a decade, and she's active in the global digital rights movement. Thanks, Veni.
Shall I go?
Yes, please.
Hi, everybody. So my name is Veni from Women on Web. And first of all, I just want to say thank you very much for the invitation to join this panel. I'm very much looking forward to the discussion and the questions that follow. For those who don't know us that well, so Women on Web is an international telemedicine service. So in other words, anyone with an unwanted pregnancy can come to our web pages, do an online consultation. That consultation is then reviewed by doctors, and those doctors then prescribe the medicines, and the medicines will be then mailed to people's home addresses. We have 11 doctors working in our team and 23 help desk members working in a total of 16 different languages, answering thousands and thousands of emails per year, providing support via email throughout the abortion process and throughout the abortion experiences. We work primarily in countries where abortions are restricted or banned, so countries like Poland, Malta, Chile, where services like ours are oftentimes the only safe, affordable, and practical way to access safe abortions. We don't charge for our services, but we do request donations, and also understand that a lot of people who reach out to us from a very precarious situation. So we also sometimes don't request the donations at all. Accessing abortions through a service like ours is also a very private way to access abortions, which is especially important for anyone living in controlling circumstances and or in a country where abortions are banned. But it's also a very say empowering way to do abortions because the service that we run trusts women and pregnant people to self-manage and to self-assess their situations, and it's really centered around the self-determination and the bodily autonomy of the people who reach out to us. But something that people don't necessarily always know about us is that we also work in countries where abortions are legal and funded. And we have a lot of people who reach out to our services from these countries as well. And what we do, we study and analyze this anonymized data in research papers. And the purpose of this is to shed light on the various obstacles that people face in accessing abortion. So a lot of there's going to be this hidden cost that we're going to be talking about today. And the research we do in countries like in the UK or Germany, for example, it informs policy debates, campaigns like yours, and really highlights that abortion is a social justice issue in the end. Barriers do exist, and these are of special relevance to vulnerable groups and identities, the youth, undocumented migrants, and so on and so forth. Our research also continuously demonstrates that telemedicine, self-managed abortions, they are a safe, acceptable, effective option to end early pregnancies. And I think what we're really seeing, especially over the last year, that it's also, we see a lot of people expressing a strong preference for managing their own abortions without the presence of doctors. So it's not telemedicine, and telemedicine is not just a response to an emergency like the pandemic, but it's something that people prefer because of the privacy and convenience that it offers. I'm going to end there, so I'll let other speakers introduce themselves, and I'm looking forward to the discussion. Thank you.
I'm the first one to be on mute. Thanks, Benny. Next, we've got Mara. Mara is the founder of the Abortion Support Network. It helps people in Ireland, Malta, Gibraltar, Northern Ireland, and the Isle of Man access safe abortions at home with pills or abroad in clinics. She's also a member of Abortion Without Borders, which does the same for people in Poland. Thanks very much, Mara.
Thanks for having me. It's nice to be part of such an international crowd. So as Carrie said, we help people get abortions. We are an abortion fund, and we exist because we think I can't afford an abortion should never be the only reason somebody becomes a parent. And our work is to smash all the obstacles that exist between someone and the abortion they want, whether those are financial obstacles, needing travel documents, insecure immigration, never having traveled before, not speaking the language, having a disability, a global pandemic. We laugh that we started an initiative called Abortion Without Borders in December of 2019, and 3 months later, Europe shut, which somehow did not stop people needing abortions or people traveling for abortions, although it did wreak havoc on the global supply chain of medical abortion pills, as I'm sure was experienced by Women on Web as it was with Women Help Women. But even though we don't technically work in England, Scotland, or Wales, we do, of course, help Northern Ireland, that's separate, horrible, but separate. Given our reputation as a creative problem solver and makers of abortion magic, and of course the fact that we have abortion right in the name of our organization, we hear from people all over the world who are having trouble accessing abortions. And sometimes we signpost them to pill providers like Women on Web. But we do hear from people in England, Scotland, and Wales. I want to say a big thank you to Dr. Sydney Culkin, who's an ASN volunteer and Queen Mary University lecturer, who actually pulled together our client contacts from England, Scotland, and Wales for a separate project just the other week. So perfect timing, Carrie, thanks. So for the past 10 years, we've heard from about 5 to 10 pregnant people per year resident in England, Scotland, or Wales. And we've also occasionally heard from abortion providers, or what we like to call massive charities, who contact ASN, which is a very small charity, who are asking for help with residents of England, Scotland, and Wales who are struggling to access abortion care. They fall into 4 categories. One, the abortion is free, but nothing else is. So if you live in Dover and you have to come to Homerton Hospital to get an abortion, and you have 3 children, and you need travel, you need accommodation, you need childcare. The second is migrants who lacked information about whether they were eligible for NHS care, as well as migrants who weren't, who we knew weren't eligible for NHS abortions. The third, people who faced unsupportive doctors or nurses in their local facilities who wanted information about where they could travel to obtain an abortion and whether or not that could be done without having to pay privately. And then people without support networks who are told by the clinic or the hospital that they must have a companion with them, either because of the anesthetic that they are having, or for safeguarding reasons. And I mean, I get why the rules are there, but we once had a hospital call ASN about a UK client who traveled to their hospital who needed to be walked from the hospital to her hotel, or they wouldn't begin treatment. And that's just bonkers. And then recently we've been hearing from a 5th category, which are people in Scotland who want pills by post, which is not currently happening in Scotland, although I believe it will be happening soon in Scotland, or maybe it happened this week and I really haven't had the chance to read the news. So as a former American who works with people in Poland and Gibraltar and Malta who have like the worst abortion laws. You know, the law here is, it's great. You know, I mean, it needs to be decriminalized and blah, blah, blah. But my God, that you birth control free and you can get an abortion and the law is up to 24 weeks. That's amazing. But as we know, legal doesn't necessarily mean accessible. And I'm really glad that that we're taking the opportunity to discuss and explore some of the gaps in provision.
Oh, thank you. Thank you. I want to remind people to put their questions in the Q&A box if you have any. We want to make sure we capture as many as possible. That's why we're doing this, and I don't want to run out of time, so just making a plea. Next up, we've got Catherine Kat Baldacchino. She's the creator and host of the Actions Responses to Trafficking podcast and head of anti-trafficking at British Red Cross. She's here in personal capacity, but she has worked in the migration field for over 16 years and previously worked for the UNHCR, the government of Malta, and various NGOs. Thanks very much, Kat.
Great, thank you so much, and thank you for inviting me as well to this conversation today. Really delighted to be here and really interested in this particular theme of discussion too, so really welcome your choice to bring this to the table. So given the brevity of this contribution, I won't manage to cover all of my concerns or the interconnectedness between trafficking and abortion, but my contribution today is specifically about the human trafficking perspective and how that overlays and intersects with concerns about abortion as well, and safe access to safe abortion. As a starter, trafficking in human beings is defined by the Palermo Protocol as a three-pronged definition. So it's the recruitment, movement, or receipt of somebody using the techniques of either force, deceit, abusing one's position of power, or taking advantage of a position of vulnerability in the other person. And it's always for the purposes of exploitation. So exploitation can include things such as sexual exploitation or forced sexual services, labor exploitation, domestic servitude, organ harvesting, etc. But that list is not exhaustive. There's continuously new forms of exploitation being created and developed. The exploitation component, however, is really key to this definition. There are many people suffering severe forms of exploitation who may not meet the full three-pronged definition that I've just laid out. So my concern and what I'll be talking about is for anyone who has experienced a severe form of exploitation, whether they meet the full trafficking definition or not. So I may use interchangeably the term human trafficking or exploitation to capture the full group of people of concern here. Also wanted to highlight that sexual violence is not confined to sexual exploitation either. Many people, predominantly the women that we've encountered and support, who have been exploited in other forms of exploitation, such as domestic servitude or labor exploitation, are also survivors of rape and other sexual abuse, often used as a mode to keep people under control, as a control device, a control mechanism, but not always. Also, just to highlight, there doesn't need to be a cross-border element, so UK nationals can be and are exploited within and across the UK. And just really to make the point that trafficking and exploitation can truly affect anyone of any background, geography, level of education or economic status. However, the people most at risk and relevant to this conversation are the people who are in situations with fewer choices, fewer alternatives. They tend to be people experiencing poverty and other complex issues that hinder ability to find alternative options and end up trapped in these sorts of situations. So my concerns here connected to trafficking and access to safe abortion is hinged around how lack of access to safe abortion can impact people in multiple ways. It can impact people's risks of being trafficked or exploited in the first place, i.e. they become more at risk of being trafficked because they cannot access safe abortion. And I'm also concerned about people's health and well-being when they're in a situation of exploitation and trying to access their options and choices and need healthcare, and also their impacts and ability to move on after they've left exploitation, and they might be on a recovery pathway and still unable to access the support they need for many of the reasons other panelists have already mentioned, in terms of knowledge, in terms of documentation status, immigration status, but I can unravel that more a little bit later, but I don't want to go over time. So that's just a quick summary of my concerns, but I'm very happy to go into more detail.
Thank you, that's great. That's great. Okay, so we've also got Dr. Audrey Brown. She's a consultant in sexual and reproductive healthcare and chair of the Scottish Abortion Care Providers Network. Her activities have focused on improving access to abortion services by opening services to self-referral, establishing a home misoprostol model, and setting up telemedicine abortion services during the pandemic. So thank you very much, Audrey. I imagine you're very busy. Everyone's very busy, but it's a busy time. So thanks.
Thanks very much, Kerry, and I'm delighted to join such a wonderful panel for this evening. So as Kerry said, I run an NHS-based abortion service, and we're based within a large community sexual and reproductive health service. We've already mentioned this evening that over 200,000 women a year in England, Scotland and Wales undergo abortion. We're focusing on abortion and poverty this evening, and a quick look at the stats tells us that if you look at 1,000 women of reproductive age, every year 12.1 out of 1,000 women who are the least deprived will have an abortion. But if we look at the most deprived group, it's more than twice that, 26.8 per 1,000 women. And women of colour are also disproportionately affected by abortion. And those figures are very similar across Scotland, England and Wales. The most deprived women are also less likely to get their abortion done before 10 weeks of gestation. So that then means the most deprived women are then at increased risk of abortion complications, which are related to gestation. And of course, you also then have a reduced choice of options. If you're already over 10 weeks, you're not going to get the choice of an early medical abortion at home, for example. So we could ask lots of things about that. Is that because deprived women are less likely to use contraception? Is it because they phone clinics later to get an appointment? Or is it because the services are actually much less accessible to poorer women? And I think I can let you make your own mind up about what I think is the answer to that. So as we touched on, abortion law is the same across England, Wales and Scotland. But of course, that doesn't mean that access is the same for all women across England, Wales and Scotland. If we quickly look pre-pandemic, all women needed to go to a clinic at the time they were appointed to attend the clinic. They had the cost of transport. Now, even if you're living within an urban area, like the city of Glasgow, if you have to take a couple of buses and maybe an underground to get to the clinic, that's actually very expensive for a lot of women. Never mind women who are living in remote and rural areas, for example, in the Highlands. Of course, you have to take time off work if you are working. And if you're on a 0 hours contract with no paid time, if you're off work, then that's going to be challenging. Not all services let children come into abortion clinics. So women, again, if you've got childcare responsibilities, would need to make arrangements. So women end up delaying consultations until they get the money to come, until they borrow the money, get themselves in debt to get to a clinic, and put themselves at higher risk by delays getting there. And of course, as was touched on by Catherine, women who have recently arrived in the country perhaps will struggle to access services. Some services may even say you have to be registered with a GP to get abortion care. And of course, there are women who are here under the radar that are anxious about being obvious to authorities and haven't registered. So things changed during the pandemic with the temporary legislation. And now telemedicine and early medical abortion at home is the most common method that's chosen. But the way that different areas have implemented that is very different. Scotland does have telemedical abortion care, and it's the most commonly used method. It's not badged up as pills by post, and access is a bit variable. So some services will offer telemedicine and post out a pack, but that's difficult. If you've got a controlling partner that opens your mail, for example, that could be difficult. Some services will do the consultation telemedicine and then you have to collect the pack. But what if you've got no money to get to the clinic? What if you're isolating? What if you're homeschooling 6 kids? How are you going to get out to collect your pack? And what if you need to collect the pack from the island that's got the clinical hospital on it, but your island has cancelled all its ferries during the lockdown? So these are the sort of challenges that we've been dealing with for women. Some services continued on as if there was no pandemic and said, you still need to come to the clinic, you still need a face-to-face. And I think, you know, if a global pandemic wouldn't make you modernise your service, what on earth will? So there's lots of people that might hold the power to make changes. It might be managers who say there's no resource to post out packs. Could be a pharmacist that says, oh, our policy is not to post medicines. But who should hold the power? I think should be the women. What works best for them? Does it suit you best to collect a medicine pack from us? Is it better if we post it? Can we arrange a specific time and place for delivery? And again, it was touched on earlier that it's not just abortion medications that women need. If you need analgesia, need pain relief for doing your abortion, for a lot of women, even buying a supply of ibuprofen and solpadeine might be too expensive. We all remember the pictures from last year where toilet paper ran out and all the empty shelves. Well, in a lot of areas, sanitary protection was the same. And certainly in the area of Glasgow where I am, sanitary towels were gone from the shelves. So that again was an issue for women. And again, if you're isolating and your next door neighbour's getting your shopping in for you, how are you meant to say, going to sling in a couple of big packets of nighttime sanitary towels? It's embarrassing and stigmatising. And of course, the cost, it's about £3 for a packet of big sanitary towels. If you need, you know, 2 or 3 packs to see you through, that's a lot of money. So what my service did was make up what we felt was an abortion care pack. So our packs don't generally go by post because they're big, because they've got painkillers, anti-sickness, sanitary towels, condoms, and a supply of the progesterone and the contraceptive. So what we did was look at how can we deliver the service. And actually, during the pandemic, there's a lot of NHS drivers that weren't being used because they were previously going to pick up Auntie Jeannie to take her to her crop a day appointment, for example. So we managed to negotiate a driver for the service who then drives around the health board area delivering packs to the woman's place of choice. So it might be her house, it could be her friend's house. An example was, can you bring it before 10 o'clock in the morning? Because he'll still be sleeping off the night before. Phone me from outside, don't ring the bell and I'll nip down and get the pack from you. And also meet me in the supermarket car park when I'm on the way back from school picking up the kids, so that he doesn't know that I've got this. So there needs to be ways and means to think around how it does actually work best for women, and particularly how it's going to work best to ensure that women who don't have resources to travel, to buy sanitary protection, etc., are able to get the same service that everyone else gets. Thank you.
Thanks, Audrey. I got chills actually thinking about how everyone has, all of the speakers here have been having to think so creatively and differently about how they help people and really kind of take the lead from what women and pregnant people are wanting and needing. I've got some questions. So Janet Mearns, who is well known to abortion rights, has asked, how do each of your organisations advertise your services? And I was going to widen that out to ask how you've had to adapt that pre-pandemic and post-pandemic. And also, sorry if you don't mind, also, I think there's this grey area as we come out of the pandemic, or this kind of period where we don't quite know what's going to happen. And I wanted to, if you could sort of say how you're planning for that or what you're concerned about with that, if that's all right for the first question. I might start with Mara.
It's not like we have an advertising budget exactly, but before we go into a jurisdiction, we contact every group that we think anybody facing a crisis pregnancy might turn to. And we tell them about our services. We don't ask them to take a publicly pro-choice stance. We're just like, hey, if somebody needs our service, here's the number to give them. We also, we're in the media quite a bit. We are friendly with grassroots activists. Every country that we've gone into, somebody has printed up stickers with our contact information and put them into ladies' toilets and bus shelters and airports and things. And of course, in a Polish context, when the Constitutional Tribunal ruling happened in October, we were given an advertising campaign that we couldn't have bought, which was, tens of thousands of people in the streets literally chanting our name and our phone number. There were songs written encouraging people to paint our phone number. We don't encourage graffiti, but if it's helpful, we'll take it. So yeah, and also we are the abortion support network and also the, also Abortion Without Borders, so that we come up pretty high on the Google rankings. In terms of concerns for the future, I'm concerned about money. I think the global economic crisis has not hit us yet. I think it's going to hit us. A lot of people are still on furlough schemes. I think, the Department of Health abortion statistics just showed us that a lot more people chose to terminate and cited financial reasons. So I think that in the coming year or years, more people getting pregnant unintentionally or intentionally might decide that now isn't the right time to continue. And then, of course, as we know, the UK just is or going to slash the aid budget for foreign aid. There's going to be people competing for smaller pots of money and, blah, blah, blah. But you know what? We'll make it work because that's what we've literally always done.
Thanks, Mara. Kat, do you want to go next?
Sure. So, I'm here in my personal capacity, so I can't really talk about my organisation, but I can talk more broadly about the anti-trafficking sector and the trends that we're seeing across the board. So I think generally, a lot of adaptation obviously needed to occur during this time. A lot of casework specifically was delivered remotely and via virtual means, which adds a lot of extra concern, including safety concerns about where people are accessing that support and who's listening in, etc. Overall, there is a very strong advocacy message across the trafficking sector about reducing risks that impact overall access to services. So trafficking survivors' access to healthcare in general is always a key concern, including for all the exact same reasons, including public transport costs, including the need to stay overnight, including a lot of confusion about whether someone's entitled or not. And as someone has mentioned, whether someone's under the radar and might not necessarily want to go to the authorities, especially as we're leaning more into a hostile environment where actually there is a real threat of people being reported and data being used for Home Office purposes. In addition to that, there is also a big push across the sector and a real collective view of a trauma-informed way of working, and so a lot of casework is delivered by service providers, by a lot of NGOs and humanitarian organizations, really focusing on exploring in a very non-directive, non-judgmental way everybody's, what people's options are, and helping people to access that and advocate for service provision if that's not being provided. But that is again for people who are accessing support, and that doesn't at all touch the the depths of the people who aren't disconnected from services. So that is obviously a key concern. And I just think the key concern going forward is just the number of people who have remained in conditions of exploitation during this past 15 months, 16 months. And the sorts of issues we're going to start to see as things open up and people can actually access face-to-face services again is really worrying and concerning, but something that we're monitoring closely.
Thanks. Venny.
Yeah, just a bit like with what Mara said as well. We don't have an advertising budget for women on web, but the website in itself, it's been up for 15 years, so it continues to generate an increasing amount of traffic. And reaches the top spots in the Google ranking. So that's sort of an ongoing thing that always is down the background. But we also do work closely with local groups, and we do a lot of, well, we used to do a lot of campaigning before the pandemic hit with Women on Waves. So that's something I think we're looking forward to doing it again. And it's something, it's free advertisement, and it always see it in our service, and an increase in requests when we've conducted a campaign somewhere. Our concerns, it's become more and more expensive to run a service like ours. There's a lot of instability and disruptions in air travel and supply chains that we were seeing that it's stabilizing, but it's very unpredictable still. We also hear more and more from people, like people are already being pretty in precarious situations when they're contacting us, but we see more and more of that, and people requesting not to have to donate to the service, and so that's happening a lot. And I think the general concern is also that although we've seen a lot of positive developments in the last year or so, like there's been countries that have decriminalized abortions, there's countries that have introduced telemedicine. I think a big concern of ours is now that we hope that the telemedicine protocols will remain in place after the pandemic. And it's anyone's guess. We've seen, well, UK, you've just had the consultation. Hopefully that will result into positive results. The same in France. They just renewed again the telemedicine, but it's still depending on the pandemic, and it's nobody really defines when the pandemic has passed and what does it actually mean, when does the protocol end and when it doesn't. And we see a lot of people are already relying on such services, and they want to continue having access to services like this. So that's a big concern, that telemedicine remain after the pandemic. And like I said earlier, that it becomes something that it's not just associated to pandemics, that it's not just the last thing people have to resort to after all the other options are exhausted, but it's something that people are entitled to.
Thank you. So I remember watching the documentary Vessel about women on web, which I recommend. And so I think it was in Ecuador when the flag went up with the phone number, and in 20 minutes, people were, women on web were inundated. So it's very powerful kind of necessary activism. Audrey, I don't know if you already answered that. Did you have anything else you wanted to add?
Yeah, I mean, I suppose we've got a website for the service, which, up front says you can self-refer, telephone consultation, and get your medicines delivered to do your treatment at home. I think from the point of view of concerns for the future, I am worried about the power that the public consultation might have. And to be honest, I'm aghast that, in this day and age, the governments in Westminster and in Holyrood at Scotland felt the need to go to a public consultation. We don't go to public consultation for other aspects of evidence-based healthcare, but it's been done, and I guess we'll live with the consequences. I very much hope that telemedicine abortion care will continue. In England and Scotland, Wales, that we know it's benefited a huge number of people, and it would be, I think, a very much backward step to remove the possibility. But I think my sort of other side of that is we need to remember there's granted a smaller number of people, but people that home medical abortion and telemedicine isn't the best solution for them. And I think we need to guard against money-saving managers, for example, that might put pressure on us only offering home abortion if you're less than 10 weeks pregnant. And there are some women whose home environment isn't suitable, they wouldn't feel safe doing it at home. So we need to be careful that we don't sell telemedicine and home abortion so hard that we take away a clinic-based service for people that do need it.
Everyone was hard nodding, almost whiplash to that point. While you're on a roll, Audrey, hang on, Mara.
Sorry, go ahead. I just wanted to make the point that we've seen that exactly happen in the Republic of Ireland, where abortion was made legal, but almost all abortion is done with pills, and a high number of people, they don't work. Not like a high number, you know, it's a small percentage, but they don't work. And then there's no place for them to get surgical. People forget that.
So while you're on a roll, Audrey, I think I might ask you this first, if you don't mind. So we've got another audience member coming with a question. I don't want to put you on the spot with estimations or nailing down exact figures, but the question is, do you have an idea or an estimate of the amount of women who might lose legal abortion access in the UK if abortion telemedicine is stopped after the pandemic? And I might ask everyone that, because I think that Fenny and Mara do have people from the UK contact them. Audrey?
Yeah, I think there will be a small number of people. It's hard to put an exact number on it, but there's certainly, we've all come across people who actually have ended up having to have a baby because they couldn't afford a bus fare or needed to go to a different health board area and just didn't have the means to get there. And for a lot of those women, as long as they're in contact with services early enough, telemedicine has managed to provide care for them. And we've certainly provided packs to a number of women on pretty remote islands in Scotland who, particularly in the pandemic, it would have been impossible to travel to the mainland to access care. I think there are people that just don't have either the financial resource or just the personal ability to be able to get themselves into a big city to get to a clinic. Some people have, are unable to leave the area that they live in for a variety of personal reasons. And for those women, unfortunately, removal of telemedicine and home medical abortion may force them into a situation of repeated unplanned childbirth.
Yeah. Catherine, did you want to come in on that? I know it's not.
Yeah, I don't really have anything to add to contribute to this question. Thanks, though.
That's fine. Mara, I know that you pull lots of stats and you have lots of stories.
And then they go right out of my head.
No.
Yeah, no, it's so all of my experience is really on people who can't access care rather than on those who can. I think based on what I've seen from people from abroad trying to come in to get service, telemedicine is great, long live telemedicine, but also, again, let's make sure that there's surgical provision. There is a postcode lottery. I know that as you get further into pregnancy, the appointments become much rarer. Like the other week, it was a 2-week wait for abortions over 20 weeks. That's not concerning. And there is this, so as you get later, it just gets harder and harder. But I also, I appreciate the question that the person asked, but like how many, but for me, one is too many. One person who can't get an abortion when they want one is too many. So I don't want to say, well, if it's only 1,000, it's all right. If it's one, it's not all right.
Thanks. Venny, you don't just have to talk about the UK if you don't want to, but I know that that is part of the people who call women on web.
Absolutely, and I actually managed to pull out some of the data from the previous research that we did and included the UK into. So when we researched the reasons for people from the UK reaching out to our services prior to the pandemic, so a few years ago, back then it was around 50% of the people were saying that the reason was access barriers that included long waiting times, distance to clinic, childcare commitments, and so on and so forth. Also mentioning prior negative experiences with abortion care. Back then, 30% of the people we researched were referring to privacy concerns. So they were talking about the lack of confidentiality of the services, the perceived and experienced stigma, and within that 30%, people were also preferring the privacy and comfort of using the pills at home. And then around 20% were reaching out to us from controlling circumstances, including partner violence and partner family control. Interestingly, then we included the UK into our research right around when the pandemic, after the first wave, had started, and we were looking at different countries. There was Northern Ireland, Malta, Portugal, and we saw a sharp increase from all countries where accessing abortions meant that you either have to travel, so it'd be Malta and Northern Ireland at that point, or Portugal, where abortions were only available in hospitals. But we saw a sharp decrease from the UK. So we saw it was something like almost 90% of the health requests went down after telemedicine was introduced. So it's pretty powerful and compelling data. But I do agree with the previous speakers as well, like telemedicine has so much potential to democratize access to abortions and lower some of these access barriers. But for sure, there's a lot to consider. There's people with homeless people, for example. It's not always an option to do an abortion at home, of course. And there's still, they're called digital divides. The divides within regions and also within countries, like people just don't have access to modern technology. So the expectation for them to find services online and use applications, mobile applications, that it shouldn't be given.
Oh, thanks. So I'm going to ask a question from a different angle about, so we're a campaign, Abortion Rights is a campaign, and we like to be active, and I think people like to have things that they can work towards. So the question is, can you put forward a kind of concept or an idea or a simple thing that can be changed, that we can campaign for, that would alleviate poverty and help the situation? I think of one of the things that Abortion Rights is currently campaigning for in the UK, off the back of the fact that Monzo put forward a paid leave for abortion policy, is to campaign for that. I think that's something that lots of big companies should be easily placed to do. And we have, just going to post it again. I've posted the wrong thing. I'll do it properly after I've spoken. We have a form where we're asking people to anonymously sort of tell us when having paid leave would have helped them, and give a bit of their story, because we're pulling together kind of cachet of experiences to make the campaign live, relevant to people. So I'm talking a bit longer because I want to give you enough time to kind of really consider your thoughts on this, because it feels like quite a conceptual, difficult question. But do people want to say who wants to go first? Oh, Audrey, lovely, thank you.
Yeah, I think that the paid leave is very important. Now, people will need paid leave to get to a consultation or time to do a consultation, but of course they're also going to need a leave day on the day of doing the abortion, and they might need a day or two to recover. I think one of the problems in the UK, there seems to be this sort of the guardians of fitness certificates or sick notes or whatever you call them are GPs. And of course, if someone hasn't involved their GP in their decision, they have reasons they don't want their GP to know. How are they meant to go about getting a sick note? So I think we need to engage abortion service providers in that. And for many years, I've given people a fairly bland letter that said such and such has consulted me in connection with a health problem. They're undergoing treatment on blah, blah day, and they'll probably need 2 or 3 days to recover. And they've handed it into their workplace or their university tutor or whatever, and never once has anyone come back and said that didn't suffice. So I think we maybe need the people that are providing the abortion just to be a bit more helpful than saying go to your GP. So yeah, I think that's very important. And again, the other thing about what else can we do to make a difference, we've touched on. A few of us have mentioned sanitary towels, and I think that's very important. If someone gets an operation done and they've got dressings that need to be changed, when they leave the clinic or the hospital, they get a supply of dressings to use. So I think we need to look at providing at least a starter supply of sanitary protection for people, and just providing a care package to support that woman to comfortably access the care she needs, whether that be providing pain relief, if the woman needs to attend a clinic, providing transport for her to get there. If you needed to go in for various other procedures, you can have patient transport services, but of course they need to be booked in advance. Abortion care is more timely than being able to book something in advance. So at the end of the day, I spend time arguing that it's going to cost the health service a hell of a lot more money if this woman either has a delayed abortion or has a baby that she doesn't want. So for the cost of us getting a contract taxi service to pick the woman up at 7 o'clock in the morning and get her to the unit for the abortion, it's money well spent. But you need people to champion that. Health service managers aren't going to come forward and volunteer transport for abortion patients.
Yeah. Oh, thanks. Fenny, did you want to?
Yeah, so I guess more on a more general level, I think the messaging should be really around how abortion care should be sensitive. Provision of abortion care should be sensitive to the needs, to the rights, and to the autonomy of the person receiving care. It's about trusting women and pregnant people, and also challenging the power dynamics between the provider and the person receiving care. And I mean, you mentioned, one of the speakers mentioned how you want to make sure that there remains equal access to options, so surgical and medical abortions. It's really important that this doesn't become like a misplaced competition between two options, that it's somewhere above the service provider. It's regulated in such way that none of the options feel threatened by the other, and it shouldn't be like a riddle or a puzzle to be solved by the providers, but it is really the government that makes sure that introduction of telemedicine or medical abortion, despite how prevalent it becomes, you still always there remains access to surgical abortions and clinics as well.
Thanks. Catherine.
Thank you. Yeah, again, I guess just talking from across the board and across the anti-trafficking sector, my suggestion or some of the advocacy points could be I guess a very general point about making the case for the variety of circumstances that people find themselves in. People mentioned previously the accommodation suitability, and a lot of people that we support, a lot of people that we see are in asylum accommodation, are sofa surfing, are in really unsuitable locations and situations, and just thinking about the fact that many of them won't even know that it might be an option. A cursory glance at the NHS website just says that all maternal care is included except for terminations, and I think a lot of people would just stop at that and stop looking and not even explore any further options. I think also appreciating a lot of cultural stigma in even verbalizing the thought of wanting to go, to have an abortion. And so therefore, caseworkers, care support providers needing to be really a lot more conscious of this in order to create spaces where people feel like they can have the conversation. And I also just want to draw a link to a big concern that I've been seeing internationally in emergency settings as well, in refugee camps and in emergency disaster settings, where healthcare is provided but not holistic, full healthcare or family planning. And so as a result, and with the further cuts to international aid as well, it's just really concerning that actually any provision that may have existed is at risk of cuts. And so any advocacy around the need for safe abortion in those settings too, where it's often an afterthought, if it's thought about at all, is really essential.
Oh, thank you. Mara.
You've known me for long enough, Carrie, you know what I'm going to say. We're not a campaigning organization, but first of all, just a really simple thing, and this is me speaking a foreign language. CCGs in the UK actually have funding to support people who must travel for care. But this funding excludes abortion because of self-referral. Some CCGs provide funding based on pre-agreed partnerships with abortion providers, but there's no consistency. And also generally it's on a reimbursement rather than a front paying. So unless you have the money to front your training, whatever. So that's something that could be addressed. But also, I think
those are the clinical commissioning groups. Right?
Yeah, sorry, I don't even know what it stands for because I don't deal with healthcare for people who are eligible for healthcare in this country. You know, I think both Catherine and Benny mentioned a lot of the people who are more marginalized and the extra needs that they, you know, that they have. And I think that's always really good to keep in mind. But for just regular people, like abortion is part of healthcare, right? Periods, miscarriages, menopause, abortion, IVF, birth. It's all the same stuff. And yet we treat abortion like it's this dirty thing. And don't get me wrong, it's like, yes, of course, there's some cultures and there's some situations, but for the rest of us, 1 in 3 of us has had an abortion. Why aren't we chatting about it at the bar well, when there are bars, you know? And so just a general destigmatization of abortion, full stop, so that we talk about it like we talk about pap smears and mammograms and what is it that the boys get? Prostate exams and, you know, diabetes checks and blood pressure and everything else. It's part of healthcare. Talk about it. I tell you, I can turn any conversation around to abortion, literally any conversation. And I just highly recommend y'all try that.
Oh, thanks, Mara. I think I feel like we've got a minute for everyone to come back, but I'll give you a bit of time to gather your thoughts. I think this has been a really amazing session, and I don't want to lose the momentum and the sort of ideas that everyone's kind of raised. I think abortion poverty is the kind of stigmatized, it's very stigmatized. On top of abortion, poverty is another thing that people don't like talking about. It's very difficult to access it's very difficult to kind of push your raise your voice and push your wishes when you're having to sort of beg for things, and that's really difficult. I think the society we live in shouldn't just be judged on, you know, the people who kind of move through it easily. We should judge our society on like the hardest, the most vulnerable. So we're not doing great on that overall. I'm really pleased to have everyone here to listen to this discussion. I'm going to obviously ask people to join Abortion Rights, and there'll be a link with how to do it. You can also volunteer with us and you can get involved in our campaigns and sign up for the newsletters we send out. So please do that, and also have a look at the next session. Next week is Going Beyond Choice. I will do the summaries backwards. So Audrey.
Yes, I suppose in summary, I would say that women from all backgrounds do need abortions, but women who are living with poverty need them even more than other women, and they struggle even more to access a decent service. So we need to make sure that we provide a service that does provide all-round care for women, and as the service fits the needs of the women. We shouldn't expect the women to fit into the model of service that we are providing.
Thanks. Mara.
I mean, keep having conversations like this, spread the word. Anytime somebody says something nonsense like, oh, well, you can just go get an abortion. Can you? Can you really? Where's your closest provider? How far do they go? You know, and also as part of stigmas, let's start demanding that our popular culture represents abortion as abortion actually exists, and not, you know, the convenient miscarriage and or the I'm gonna keep the baby and raise it, or, you know, the fact that almost every woman who has an abortion in media is like a white woman. Yeah, so just keep up the talking, have more panels like this.
Thank you. Catherine.
Thank you. Yeah, I think my summary is just to continue and this is probably targeted more at the anti-trafficking sector, but just to really appreciate that any sort of care and support and program responding to trafficking by its very default needs to include provision for safe abortion within that as well. Because everyone's intention, of course, is to reduce the risks of being trafficked in the first place, and to recover more and more people from situations of exploitation. And without access to safe abortion, more people are going to be at risk of being exploited in the first place, and more people are going to decrease the chances of breaking that cycle and potentially returning back to exploitative situations as a result. So I just think it's all connected, and it's one of the most fundamental aspects, as well as part of holistic care, that isn't always considered at the moment as part of the basis of provision.
Yeah, thanks. And Benny?
Yeah, echoing a lot what Mara already said, when we talk about hidden costs or these hidden barriers, like I encourage everybody to think beyond the formal difficulties of accessing abortions, and really challenging to think what those barriers can look like, how something very simple like getting on a bus or buying a metro ticket can seem so obvious and so easy for somebody to do, and then for another person the situation can be widely different. So yeah, let's continue talking, let's continue challenging ourselves, and really trying to step into the shoes of all these women and pregnant people and their different situations.
Oh, thank you. Thanks, everyone. We're a minute over 8. But our email is choice@abortionrights.org.uk. So if you've got any feedback or you've got suggestions for future panels that we can run, or future speakers, please get in touch with us. Thank you very, very much to the speakers for giving up your time and for preparing your contributions. And thank you very, very much to the audience. Hopefully see you next Wednesday.